All right, hello everybody and welcome. My name is Laura Hawley with the Munroe-Meyer Institute. I want to welcome you to the Telebehavioral Health Consultation Primary Care webinar series. Today's webinar is on depression in pediatric primary care by Dr. Ryan Edwards. This webinar is sponsored by the UNMC Telebehavioral Health Consultation Team, which is part of Nebraska's Pediatric Mental Health Care Access Program. We provide consultative support to primary care providers in Nebraska, managing patients with mental and behavioral health problems within their medical home. Providers are able to offer guidance on diagnosis, medication management, and behavioral health interventions. This program is supported by the HRSA Maternal and Child Health Grant awarded to the Nebraska Department of Health and Human Services. More information about this is available on our website shown here. Next slide, please. If you have questions at any time during the webinar, don't hesitate to type them into the Q&A box shown there. Next slide. And I'd like to turn this presentation now over to our speaker, Dr. Ryan Edwards. Dr. Edwards is an assistant professor in the Department of Psychiatry at the University of Nebraska Medical Center, as well as the Division Director for Child and Adolescent Psychiatry. He also works at the UNMC Psychiatry Anxiety Subspecialty Treatment Clinic. Whenever you're ready.
All right, thank you, Laura. Yeah, like I said, I am Dr. Ryan Edwards. Just trying to make sure that the video is working here. Okay, there we go. All right. I'm Ryan Edwards, the Division Director of Child Adolescent Psychiatry. Thanks again for logging on for this continuing education credit. Feel free to type the questions in, though I'm not sure I'll be able to monitor them. I'll have Laura compile them. And Laura, feel free to interrupt me during the presentation if it's a question that seems pertinent to the slide, or else we can have time at the end, about 5 or 10 minutes at the end, to compile the questions and then ask any live. So this presentation was meant to be an overview of depression in the pediatric primary care setting. Most of it is going to be directed at pediatricians and family medicine physicians caring for adolescents and children with mental health concerns. But hopefully it'll also be a really great overview for any mental health practitioner, psychologist, social work background, therapy background, or a nursing background, anybody who's in. It kind of gives us, I'm going to present some evidence on what depression looks like in youth, and discuss risk factors and the impact of depression. And of course, most of the session is going to be evidence-based practices for management, but also I'm going to give my spiel about how I tend to work through psychoeducation with youth coming in for depression complaints, and how I explain the evidence base and the risk factors for and against all the treatment modalities. So hopefully you can kind of see how I present the information from a subspecialist standpoint, and you can kind of modify it for your own primary care setting. And I'll give you the pearls that are most important. All right, so a little bit of background here. So major depressive disorder. So I'm going to use major depressive disorder and major depressive episode a little bit interchangeably, and I'll describe some of the differences as we move on. But some background here, it's pretty common, right? 2% in children, 4 to 8% in adolescents. After puberty, it starts to become a bit more female predominant, and the cumulative prevalence is pretty striking, right? 20% by age 20. And I'll tell parents this, I'll tell youth this, that you're in pretty good company. And depression is really, unfortunately, very common in youth, but the goal of depression is treatment. It's a very treatable condition. And if we get through this together, chances are that you'll live a full, healthy, normal life if it's a major depressive episode. And then in some ways, it can even build resilience if we can adequately treat. So when we talk about who's at risk for developing major depressive episodes, who are these 20% of youth? Well, we know that genetics is a huge risk factor, right? It runs in families, and we've seen that with high-risk studies, bottom-up studies, adoption, twin studies. It's really the single most predictive factor when we're talking about risk factors for depression. Family history is critical. I always ask about family history of depression, major depressive episodes, and suicide attempts, completed suicides in families. I'll usually ask those three to give me a good sense. A little bit about bipolar disorder screening in later slides, but that's also important. Heritability, right? About 50%, which is high, right? That's pretty high when we're talking about heritability risk factors in our medical literature. So, when we talk about the whole nature versus nurture debate, it's really interesting when we're talking about how epigenetics can play a part of that. And so sometimes I'll tell parents this too, that in some of our studies, homozygous or heterozygous kids with a less functional allele for neuronal serotonin presynaptic reuptake, which is what our medicines target, and serotonin is thought to be one of the major mediators of mood, depression, and anxiety. They're more likely to develop an MD, major depressive episode or major depressive disorder when exposed to recurrent negative life events, right? So would they have all, they kind of have that priming, to develop a depressive episode under a stressor that maybe someone who didn't have the genetic predisposition maybe would not have, right? So that gets at a lot of really interesting discussions about, nature versus nurture. How much does the bidirectional aspect of depression interplay with family-based systems and then things that happen to kids? Very complicated, but what we do know is that it's highly heritable and that there are a number of other factors that go into play. So when we talk about that bidirectionality too, we've had some studies that look at parental, and especially maternal depression has been associated with less responsiveness to youth and CBT, and successful treatment of mothers associated with fewer new psychiatric diagnoses and higher remission rates in children. There's some other studies like depressed fathers, and in a male-female co-parenting relationship. So depressed fathers who have postpartum depression or any time depression in a kid's life, that youth is at higher risk for developing an anxiety disorder, for instance. So there's lots of interplay here, of course. And then we talk about pre-morbid psychiatric conditions. So if the youth had struggled with ADHD beforehand, but was relatively well controlled, there's still, a little bit higher risk for developing a major depressive episode. Not nearly as much as the big one that we worry about, the big psychiatric comorbidity and pre-morbid condition, social anxiety disorder. Social anxiety disorder is the highest, is the psychiatric illness with the highest risk of going on to develop a major depressive episode. So when you diagnose or suspect social anxiety disorder in an adolescent or a child, just be aware, very, very relatively high risk of going on to develop a major depressive episode if left untreated. So we really want to be aggressive with especially psychotherapy referrals to get that social anxiety disorder treated. And then, of course, history of substance use, trauma, their ACEs score, right? Adverse childhood events scale, lower intellectual functioning, higher risk factor for depression, socioeconomic status, family social supports, negative cognitive styles. So if the youth is just kind of primed to have that kind of anxious, ruminative, automatically thinking the worst case scenario, even outside of a generalized anxiety disorder, may be more likely to get warped into a major depressive episode. Major depressive episodes in youth last about 8 months, and this is the most important figure: 20 to 60% recurrence rate. Right, this is why we treat to remission, and we treat. We make sure to move into a model of depression relapse prevention, which is a pretty active arm of treatment as well, which I'll talk about too. And the risk factors, just kind of like on the previous slide for reemergence, are similar. And we talk about suicide. So this kind of bullet point here: youth with depressive disorders are at high risk for suicide attempts. Okay. It's understandable why untreated major depressive disorder is high risk for suicide. 60% reported suicidal ideation, and 30% have attempted. That's a pretty striking figure. So major depressive disorder is among the highest risk factors for suicidal behavior in youth. But we really do tend to think about suicidal ideation and suicide behavior even separately from major depressive disorder. We kind of think about that major depressive disorder as a major risk factor for suicidal behavior, but we want to screen for it and treat it independently, even if we're not diagnosing a major depressive episode. As such, if we want to have an entire lecture or an entire, noon series of just suicidality in youth, that's a whole separate topic. But what I will say right here is that the risk factors for suicide attempts in youth is the #1 risk factor, right? This is always a board's question. It's something that we pimp our medical students on all the time. What's the #1 risk factor? History of prior attempts, which seems intuitive, but it's a critical piece of information. So if we have a youth coming in we suspect depression or suspect a relatively elevated risk for suicide for any reason, we always ask, have you ever had these thoughts before? Which is a very different question, but equally as important to, have you ever tried to kill yourself before? I've had a lot of youth say, no, I've never really had these thoughts before. And then I ask the independent question, have you tried to kill yourself before? And then the answer is yes. And that leads to a discussion about what it actually means to them to not really necessarily have ideation or ruminative desire to die and actually trying to kill themselves. Okay, so it's important to ask those two questions. And that kind of gets at one of the other major risk factors for youth and suicide is impulsivity. We know that a lot of suicide attempts are impulsive. NSSIB is non-suicidal self-injurious behavior, like cutting. We used to think that it wasn't as predictive of suicidality in kids, but what we now know that non-suicidal self-injurious behavior is an independent risk factor for suicidal ideation and suicide attempts in kids. So we screen for it separately and independently. We understand it as a risk factor. Just kind of getting off topic here, starting to go down the line of suicidality because it's so important. What we do know is that if there is self-injurious behavior, that's an independent risk factor. If they have suicidal ideation, it's an independent risk factor. If they're temporally related, it's a much higher risk. So in other words, it's very concerning if youth has suicidal ideation, active suicidal ideation, and they engage in self-injurious behavior in an effort to cope with those suicidal thoughts. That's very concerning. Even if they say, no, I wasn't trying to kill myself when I was cutting, if they're temporally related, suicidal ideation with self-injurious behavior, that's really concerning. And so I'll screen, I'll ask, yeah, you have cutting, yeah, you have suicidal ideation, tell me about it, and how they're related, if at all. Sometimes they're not, sometimes they are. Family history of suicidal behavior, right? And then availability of lethal means. So anytime I diagnose major depression, I'm always asking about lethal means. So, in teenagers that are of driving age, we talk about that missile that they're piloting, and safe driving behavior. And then of course, the big one is guns. I document, guns in the house and whether or not they're locked up, what kind of guns they are, what they're used for, sport, protection, hunting, whatever, document it. And then exposure to negative life events. So, physical illness, which we'll talk about, early pregnancy, poor work, academic performance, psychosocial functioning are all risk factors for depression, right? Okay, not necessarily for suicide. And then we expect a slow and gradual improvement in the functioning following a major depressive episode. So that's another thing I'll tell kids, right, is that it's really common as we start to recover from a major depressive episode, the people around you will tend to notice your functioning improving and you seem a bit better or brighter before you actually feel any difference. Okay, so that's really, can be really frustrating for kids. Other people are saying they're looking better, but they're not feeling it yet. That's common when we talk about kids emerging from a major depressive episode. We talk to them about that this is likely to happen, and we kind of normalize it as part of treatment because that's also a potentially higher risk time for suicidal behavior. It can be really hard as a teenager, with your friends saying, oh, you look so much better, you're smiling actually, wow, that's great. You don't feel like it, right? That can really reinforce any lingering feelings of guilt, hopelessness that you have, okay? But we have kids really engage in treatment, and we really tell them that's an expected part of treatment recovery. Okay. So we're talking about assessment now. So the most useful tool is clinical evaluation, your clinical assessment. Okay. We have screeners, we have validated rating scales that, take, anywhere from a couple of seconds all the way to a couple hours to administer, but clinical evaluation is the most important part. That's because adolescent depression in particular is a very heterogeneous, very messy disorder. It's really mired by psychosocial factors, much more so than adult depression, which is, tends to be a little bit more, by the book, and you can go off the criteria. So you really need to use your clinical judgment, really take what the adolescent is or is not reporting in the context of their developmental emotional age, whether or not that maps onto their chronological age. Sex, gender, gender identity is something that I always screen for every time. Environmental conditions, cultural assessments, religious backgrounds, okay, and what is maybe normal in that setting. There are no biological imaging tests, I usually don't say that unless I'm asked, but yeah, there's no imaging tests yet for depression. And so I tend to ask a lot of questions that kind of relate, kind of use the adolescent in particular's own words. Okay, you say that you're not depressed, but kind of are really angry. Well, how do these feelings affect your day to day? Are you having friends notice you? Or is anyone else saying that you're acting differently? Okay, well, you did mention the word depression. So tell me, what does depression mean to you? And then what would you like to see better? If you didn't have depression or anger, what would be different? How would you know that you didn't have depression? Those are all great questions to ask a youth. And then a mood diary can be really helpful, especially if things are really messy and there seems to be kind of waxing, waning episodes of a lot of chaos going on in the kid's life, and you're not really sure, what is environmental or what is, just normal stress reactions to abnormal situations. A mood diary can be helpful. Have them write on a scale of 1 to 10 how they're feeling, that day, and then kind of map that on to see if anything else is happening in their life. That's a really simple, easy thing to do, even from a primary care office. Like, hey, get a calendar, chart your mood 1 to 10, and then bring it back. You're going to tell me what happened, if anything. We'll figure it out. Okay, that along with like your PHQ-9s. So PHQ-9s are great. They're not made to be a diagnostic tool, even though these are the diagnostic criteria, right? For the DSM, major depressive disorder, major depressive episode diagnostic criteria. They're right there. So not intended to be a diagnostic tool, but is an extremely helpful screener. You guys, as pediatricians, I see it all the time. You're using it really, really well, and you're catching a lot because you're just handing this out at a regular well child check, and we're seeing stuff that the youth may not report automatically, or even might deny if you're in an evaluation with them. So these are great. And, kids won't typically report, I feel sad. Even if they do say, I feel sad, it doesn't mean they're depressed. Even if a teenager says, I'm not depressed, doesn't mean they're not depressed. So look for some other signs. This is where clinical evaluation is really important. Children tend to be more irritable, low frustration tolerance, temper tantrums, somatic complaints, belly aches and pains, okay? Just kind of like anxiety disorders. Hallucinations, right? Can be really scary for kids. Seeing things, especially like the hypnagogic, hypnopompic hallucinations around waking or falling asleep. Social withdrawal, okay? Teenagers, irritable, right? A hallmark of depression in adolescence, irritability, okay? If I have a complaint of a teenager who comes in for 6 months of increased irritability, I'm immediately thinking about, depression as the most concerning thing from the mental health standpoint that's contributing to that. They tend to verbalize their feelings more. They may not always use the words depression, and they might have suicidal thoughts or more melancholic type of symptoms, which, melancholic depression is a lot kind of the lead paralysis, the physical manifestations of depression. Food doesn't taste as good anymore. A lot of existential type hopelessness. Kind of reminds me of the movie Melancholia, if anybody has seen that. Really wild movie, but it's about melancholic depression is what it's really about. Great movie. Anyway, probably shouldn't say that. But I just watched it again the other day as we were still in the midst of the pandemic. Okay, anyway, this is how kids report depression, right? Feeling low, down, cranky, sad, empty, crying, have a bad feeling, kind of this impending sense, just something isn't right, just something doesn't feel right. Be on the lookout to screen for depression. When we talk about a mental health differential diagnosis, seasonal affective disorder, adjustment reaction, persistent depressive disorder, I don't really care about those three too much because if I diagnose a major depressive episode, I don't really care if it's necessarily seasonal. I don't really care if it's an adjustment reaction, if they meet criteria for at least 2 weeks at a time. 5 out of the 9 diagnostic criteria. I don't care if it was in relation to like a major stressor or a family death. If they meet criteria for a depressive episode, that's all I really care about. That's what we need to treat right now. We can work out kind of the semantics of it later. Now, if you had the time as a pediatrician, or if you wanted to, or as a therapist, if you wanted to kind of figure out some of the nuances, yeah, you know, especially if they're like not quite meeting a diagnostic criteria for a major depressive episode, they're still functioning okay. You can kind of, you know, spend a little more time to kind of pontificate. Is this more of a seasonal pattern? Is it relation? Let's, you know, think about, is it, you know, is it relationships to, you know, your parents' divorce? Let's explore that. Persistent depressive disorder is more, they can meet criteria for a prolonged major depressive episode, but really you can have sub-threshold for meeting criteria for a major depressive episode that never achieve like full remission. Sometimes we'll call it a persistent depressive disorder if it has gone on for at least a year or 2 years. And the concerning thing about this persistent depressive disorder is you can have what's called double depression, where you have multiple major depressive episodes on top of a baseline depression. Never really achieve full remission. Those kids are pretty difficult to fully treat. And we usually need to get really creative with, you know, novel or, you know, psychotherapeutic modalities, or making sure we're really not missing any underlying trauma, things like that. Comorbidities may pop up. Okay. All right, so we'll get on a bit of a soapbox about bipolar disorder now. Bipolar disorder is rare, okay? It's about 1% in the general, even adult populations for bipolar 1 disorder, so it's rare. But we do need to know that during the most common presentation for bipolar disorder onset in a teenager is a major depressive episode, okay? Without any hypomanic symptoms, right, necessarily beforehand. Sometimes there are. In retrospect, maybe we're able to pull them out, but first time they come to clinical attention for a bipolar disorder onset is a major depressive episode. That's the most common. Really difficult to determine, is this going to be a bipolar disorder or a unipolar depression? A very important piece of information, right, because it has profound impact on our choice of treatment, medicine-wise. So, you know, I personally am not afraid to treat with an SSRI. I personally think that almost everybody, you know, deserves a trial of an SSRI, but I want to be really careful. So during that first major depressive episode, I'm screening for family loading of bipolar disorder. And my screening question for family, does anybody in the family have bipolar disorder? Oh, okay, your uncle has bipolar disorder, or your dad says, you know, has bipolar disorder. I'll ask the guardian, what kind of bipolar disorder? Is it bipolar 1? Is it bipolar 2? What is it? If they don't know, or they're not sure, you know, I will kind of ask more questions. Have they been hospitalized before? Have they been psychotic before? Do you know what medicines they were treated for? Okay. If I hear, yeah, my dad has bipolar disorder and he was treated on a medicine that affects your kidneys, like lithium, that's it, right? I'm much more inclined to understand that family history is indeed positive. Now, I get a family history of bipolar disorder, and oh yeah, my you know, mom says that you know, that her sister or something has bipolar disorder, but in reality, when I screened for that more, she's, they've never been hospitalized. They have been stable on an SSRI for quite some time. They just have mood fluctuations. I don't consider that to be bipolar disorder necessarily. Not diagnosing a person I've never seen, but it doesn't ring as high of a risk factor for history of psychosis, hospitalization, mania that you can pull out from a family history. Or if they say bipolar 1 and they've been on a mood stabilizer, that's a positive family history. So I really kind of make sure. Kids that have a history of psychosis, hallucinations prior to the major depressive episode, more likely to go on to develop bipolar disorder. Subclinical hypomanic symptoms. So especially if I hear a history, I always screen for bipolar disorder, right? Hypomanic symptoms prior to the depressive episode. And if I hear things like insomnia without exhaustion is my #1 screen. Have you ever not slept or gotten just 2 to 3 hours of sleep for 2 to 3 nights in a row? And, the youth says something like, yeah, it was really weird. I felt different. I didn't feel tired. My friends say that I was acting funny. Or I hear the family members say, yeah, tends to start to be, if I get a sense of more of a cyclical nature to those possible hypomanic episodes, insomnia without exhaustion with behavioral changes that seem to cycle, then I'm more worried about a potential bipolar disorder. But if I'm hearing just a lot of like huge emotional swings up and down all the time, Jekyll and Hyde, their moods tend to fluctuate minute by minute, hour by hour, I'm not as worried about a premorbid bipolar and maybe more concerned about something like a disruptive mood dysregulation or, anxiety disorder or something like that. Okay. Cyclical hypomanic episodes is what you're looking for. And then, of course, if they've been on an SSRI before and they're like, whoa, I could sleep for a few days and I was talking really fast and I felt really, really edgy, then I would be more cautious. Doesn't mean you don't try an SSRI, another one, but, you just want to be a little bit more cautious. Start low, go slower. Differential diagnosis. Is this substance induced? I get a substance use history and most of the time get a urine drug screen on all my kids I diagnose with a novel major depressive episode. Is this, and then, the question, right? Is this normal? That's a big question, right? Especially in times like this, right? A pandemic. Medical anthropologists have mused some really interesting things that maybe the reason why major depressive disorder has been allowed to propagate through our species so prolifically, potentially it has a protective factor during pandemics, right? Which is a pretty wild thing when I heard it, but it does tend to make sense, when we're in a pandemic, things like isolation from friends and family members is protective, and that's the hallmark of depression, typically, right? Irritability that drives other people away from you during a pandemic might not be such a bad thing. So again, I don't usually tell parents that because, or kids that necessarily, if they're in a depressive episode, because if they meet criteria for a major depressive episode, it's not normal, okay? And I'll tell them that. It's like, this is not a normal state of being, and we need to treat it if they meet criteria, okay? So medical workup, my standard is, per our guidelines as a child adolescent psychiatrist, I always get a CBC, CMP, thyroid studies, and a urine drug screen. I rarely see kids that are referred to me come from a pediatrician that have already had these labs done. That's usually pediatricians, are much better at kind of monitoring clinically. They're doing physical exams at every visit, and they typically know the kids since birth. And so they clinically have a lot better suspicion if there is like a thyroid issue or an anemia or even something more malicious, right? Like a leukemia or something that could be contributing instead of a major depressive episode. And so, but I'll usually get the labs anyway, just as a baseline. And then also on the differential, right? There is a diagnosis out there in a major depressive, in our DSM-5 that's called major depressive disorder, secondary to a general medical condition. And these are the ones, right? Hypothyroidism, mononucleosis, they will push people into a major depressive episode, a clinical major depression. And yet, you know, the underlying etiology is actually a medical issue. And so we tend to, that's why there's a whole separate diagnosis, okay, for these things. Contrary to chronic medical conditions with higher rates of depression, epilepsy, migraines, inflammatory conditions such as IBD, they won't necessarily push people independently into a major depressive disorder, or it won't medically look like that. But they have a high comorbidity with depression, and we see it as like a predisposing factor, those chronic medical conditions. And then, you know, the things that we can kind of do, be mindful of medicines like stimulant withdrawal syndrome, kid that's been on psychostimulants for some time, abruptly stopping them for whatever reason. They might have a couple of weeks where they feel more lethargic, down. Okay, that usually gets better. Of course, steroids, and then some contraceptives too. So, okay, let's talk about treatment for the last half here. Treatment. Goal is remission, okay, of a depressive episode, complete remission. And that's, you know, that's really defined from a research standpoint as the absence of a major depressive disorder criteria, okay? Which means, you know, no more than one significant symptom of depression, or a 50% reduction in severity of the symptoms that are occurring right now, okay? And a complete restoration of function. That's our goal. So when we talk about treatment for a major depressive disorder, mostly in an adolescent or pre-adolescent, okay, I talk about 3 components of treatment. And so this is my spiel, psychoeducation spiel for the treatment of major depressive disorder in teenagers. I will draw a pie chart on my whiteboard. It's like right over there on my wall. I'll draw it. I'll say, hey, this is the treatment, okay? We can talk about therapy, we can talk about medicines, and then these are the things that you can do and your family can do to help lift you out. This is what I recommend, is this 3-pronged approach. If, you know, you say, I don't want medicines right now, it's like, okay, you know, but, you know, the stuff that you do is going to have to fill in more of that gap with medicines, and your therapist, you know, might have to, it needs to be aware that we're not treating with medicine, so that, you know, he or she can potentially help accommodate for that, okay? And this is, by the way, when I'm talking about this approach, it's with moderate to severe major depression. Because what our evidence says, we diagnose a major depressive episode in an adolescent if it is clinically, if it's by the books, if it's by the DSM-5 criteria, as mild. Recommendations are, you know, lifestyle interventions, the things that you can do as an adolescent, and psychotherapy, evidence-based psychotherapy, okay? If it's a moderate or severe, by definition, category of disorder, in my mind, moderate, if they're having active suicidal ideation, it automatically puts it into a moderate phase. If their grades have dropped from A's and B's way down to like C's and D's, it's at least moderate, okay? So that's that 3-pronged approach. That's when we talk about initiation of medicines as well as therapy. So what this slide should tell you is that of the piece of the pie, I would say, if I had to choose just one piece of the pie, it would really be a therapist. It would really be evidence-based psychotherapy. If we only had to choose one, a good high-quality evidence-based psychotherapy referral is probably going to be the most important aspect of it, okay? But what our data says is the comprehensive thing is important. All right. So when we talk about you, the things that you can do to help your depression, I will tell kids 3 things that you can do. And I want you to pick at least one of those things to work on. We'll work on the other 2, you know, when we come back, okay? 3 things you can do. Number 1, fake it, okay? In psychological mumbo jumbo, it's called behavioral activation. I call it fake it till you make it. You don't enjoy playing tennis like you used to, or hey, you know, you say that your buddies have noticed that you're not on Call of Duty as much anymore, you know, for the video game rallies. Then I will say, did you do those things that used to make you happy? Even though they don't make you happy right now, try to do them. And the more you kind of are around people that are a positive influence on your life, and the more they kind of reinforce, even snippets of happy feelings like you used to, the better it'll get. Well, and what this is really getting at is the isolation that can be really, really impairing and cyclically reinforcing in adolescent depression. So that's the behavioral activation component. We really want them to get out of that isolation funk. Number 2, sleep. Okay, I go through my basic sleep hygiene. Adolescents need 9 to 10 hours of sleep a night. Okay, adolescents naturally have a delayed shift in their sleep cycle. So natural for an adolescent to, as a kid, they were sleeping from 9 to 6 or 9 to 7. Now, adolescent naturally will want to sleep from 11 to 8. Oh, you have school starting at 7. Well, it's going to be tough, but we just need to fight back against your natural teenage inclinations and the way your brain is built, and really make sure we get sleep. This is my just basic protocol. No exercise 1 to 3 hours or large meals before bedtime, no electronics, blue screens of depression, right? The blue light, even an iPhone turns on to the nighttime mode, right? That yellow shift that they do, turn down the lowest brightness setting, it still emits that bright blue light. Any LCD, LED screen will do that. That will interfere with sleep. Cool, dark room, no caffeine afternoon, same bedtime, social rhythms. Here's the third thing, exercise. This is really exciting. In the past 10 years, there have been more and more trials saying that exercise is an independent treatment that can help major depressive disorder. It's evidence-based, which is really exciting, a non-medicine, non-therapy option for major depressive disorder. So I usually say 30 minutes of continuous exercise 5 days a week. Hey, let's start off a couple of days a week, choose 2 days, 30 minutes. Sometimes I'll even write it on a little script pad, a prescription for exercise. Very powerful in helping independent symptoms of depression. In motivating youth, preferred activities tend to be better. So, what do you kind of like to do? You like to go for a walk around the block. Well, let's go for a walk, 5 times around the block and really kind of keep your pace up so that you're breathing hard. There's some conflicting data on durability. Some studies show early benefit, others more like the effects are seen like 3 months down the road, but by and large, there are positive studies. Okay. So how about medicines and therapy? This is the other thing I'll do. If I have time with kids, with teenagers, I'll write up on the whiteboard. It's like, hey, there was this study called the THBC. And I'll say THBC, the treatment of adolescent depression. It was a big study. It really helps us kind of understand what can help with your moderate depression. So there were 4 different treatment arms. I'll write them up on the board for you. Let me know, which one do you think is going to be the most helpful? Do we want to do therapy alone? Do we want to do a medication alone, medicines plus therapy, or placebo? Which one do you think had the best effect? Okay. A lot of times snarky teenagers will say, oh, placebo. And I love that answer because it always leads into a great discussion about, yes, placebo response is powerful. Don't get me wrong. I'll even kind of say to the parents, sometimes like, hey, SSRIs sometimes are found to be like 50% placebo. Placebo effect is powerful. But we always go back to, of course, it's number 3, right? CBT or therapy plus SSRIs really gives the most robust response. So let's talk about therapy for just a couple of minutes here. There are, when we talk about evidence-based psychotherapies, I usually tend to say, there's 3 main ones. There's 3 big ones. The 2 that have the most substantial evidence base are cognitive behavioral therapy and interpersonal psychotherapy. And then kind of a newer one that I think is really cool that, some therapists are becoming more and more experts in is called acceptance and commitment therapy. Cognitive behavioral therapy, I'll usually draw the triangle out, the CBT triangle. It teaches you how your feelings interact with your thoughts and behaviors. It teaches you how to kind of cut and intercept those, at each juncture to help yourself feel better, okay? There's like homework associated with CBT. Interpersonal psychotherapy is a great one for like a really moody, irritable teenager or who is isolating a lot more. the premise of interpersonal psychotherapy is to kind of bring people that were to understand, more people that are kind of outside your sphere of support and ways that you can effectively communicate with those people to bring them in closer to you. Okay. Acceptance and commitment therapy is really kind of a cool combination of a lot of the behavioral strategies associated with CBT, but combined with a lot of dialectical behavioral elements, including mindfulness, taking a more passive approach to some of the more distressing thoughts or the suicidal thoughts, and keeping the adolescent moving forward that is in alignment with their goals and their values. Okay. How about medicines? So from a pediatric and a primary care standpoint here, Prozac, okay? Fluoxetine. It should be first line. It is the gold standard, and I'll explain why. And it's become the gold standard just relatively recently, in the past 10 years. It's the most studied, largest efficacy data. Biggest difference between placebo and medicine. I'll get to that the next slide. Here's the other thing I really like about fluoxetine, especially for adolescents. Big, long half-life. If you miss a dose, it's not a big deal. Okay, it really isn't. In fact, you can even dose fluoxetine weekly. I wouldn't recommend that, but it is a prescription available. You can do 90 milligrams, which is about 90 milligrams every Sunday night, which will give an overall effect of about 40 milligrams per day. So it's a nice medicine if you miss a dose. It's the only FDA-approved medicine for kids between the age of 8 and 18 years. Okay, so that's a big one. A lot of parents are like, yeah, give me something that's FDA approved. Lexapro or escitalopram is approved in depression after the age of 12. Okay, but those are the only two. Internationally, it's very well recognized. Okay, so there's been a few big meta-analyses that have come out that have looked at all the different SSRIs and treatment for children and adolescent depression, and it was pretty sobering data. In those studies, fluoxetine was the only one that separated out from placebo. There were a lot of methodological issues with these big meta-analyses, and other randomized controlled trials have shown that other SSRIs do have evidence, efficacy for treatment, but in the grand scheme of things, fluoxetine really came out. And that tells me a couple of things. Number one, it's easier for pediatricians to know. Start with Prozac, right? Best evidence base. But it also kind of, I think, explains the heterogeneity and the messiness of adolescent depression, right? And how powerful maybe the placebo effect really is. Okay. A lot of these studies have shown that placebo is about 50% of an SSRI. Response rates for an SSRI like fluoxetine, I tell parents, is about 60-70% chance that it'll work. Maybe about 50% of that is placebo. When we look at the data, yeah, that may be. That's okay. All right. Evidence that Prozac is better than placebo. That's why we use it. And here's how we use it. Here's how I would recommend using it. Don't start at 20. Start at low dose, prescribe a 10 milligram capsule for a couple of weeks, daily for 2 weeks, and then re-prescribe a 20 milligram capsule. Okay. A lot of kids that have a history of maybe some hypomanic symptoms, maybe they have a family history of even a bipolar 1 disorder, but they're majorly depressed. I still want them to be treated with an SSRI. There's liquid form of Prozac. You can dose it into 1 milligram, 2 milligram increments. We go really slow because they're very somatically preoccupied that the chances of more behavioral activation or somatic symptoms might reinforce anxiety in them. I'd start low, go really slow. Okay. No faster than 10 milligrams starting dose. Okay. So what we do is we get up, I'll tell parents, let's get up to 20 milligrams, and then we hold for 4 to 6 weeks to gauge efficacy. We get a partial response, at least some minor improvement. Yeah, the teenager doesn't feel it, but hey, parents are looking at it. After 20 milligrams at a month or 4 to 6 weeks, we'll keep going up at 10 milligram increments, reassessing every 4 to 6 weeks until we achieve remission. Maximal dose is probably around 80 milligrams. Okay. So if we get no response at all, nothing, or worsening of symptoms after 4 to 6 weeks, a solid 6-week trial at 20 milligrams, and things are not headed in the right direction, psychiatry referral for sure, but feel free to try a different SSRI. That's the next line in what I would do in trying it. Take them off Prozac, cross-titrate them with escitalopram or sertraline. There's a nice slide, that it kind of has a pocket reference card for you for all the other SSRIs and some of the other trials if you like. So how do we monitor SSRIs? So my spiel for, I know this has kind of been, drilled into people over the last few years, but there is a black box warning. So what I'll say, hey, you'll notice that there's a black box warning on this medicine called fluoxetine. That means a special designation has been given by the government that says these medicines are associated with suicidal thinking and behavior in teenagers. Okay, let me explain that. Okay, they usually say, oh my God, why are we giving a medicine used to treat these depression and suicidal thoughts, that if it can make it worse? The black box warning came about from a study in the UK where there were 400 kids. They gave them fluoxetine, and they found that the suicidal thinking, not behavior, or completed suicides went from 2 to 4%. Small, but statistically significant increase. That was enough to get that black box warning on there. In the past 20 years, there's been multiple studies that have looked at that association. There hasn't been any data that says these medicines do cause suicidal thinking, and yet there's still an association. We're not exactly sure why that is. It could be that, and this is what we know, that any change in treatment or change in structure is a time when we need to monitor for increased risk. Your teenager is already having a depressive episode. They might already be having suicidal thoughts, or they are already having suicidal thoughts. So therefore, whether or not we decide to move forward with Prozac or medicine prescriptions, my recommendations are going to be the same. You need to monitor carefully. I don't recommend any increased monitoring whether we start an SSRI, because we need to monitor really carefully from here on out. Okay, that's usually good for parents. I always talk about also the risk of activation, okay, which is not hypomania, but it looks weird. About 10% of kids become activated on an SSRI, slapstick silly, a little bit more disinhibited, a little bit more impulsive. Okay. And then I always also say, hey, I don't think your kid is at any higher risk for developing bipolar disorder, or even if they are at an increased risk for developing bipolar disorder because your dad has bipolar, here's the symptoms to watch out for. If I'm wrong, I could be wrong, that this is the start of a bipolar disorder, here's how we'll know. These medicines would not be good for you if you have bipolar disorder. We're going to need to stop it right away. Here's what to look out for: insomnia without exhaustion, drastic changes in behavior, cyclical nature to those symptoms. This is my smart phrase I use, okay? This is what I document at every visit. I hand parents the sheet of SSRI risk benefits, and I talk about this, and this is what I document, okay? And I do, and I describe it. So here's what the FDA recommends, is that in novel initiation of an SSRI, clinical contact and monitoring every week for 4 weeks and every 2 weeks thereafter, which is a lot, right? I can rarely get people in a week for routinely starting an SSRI, but I will get them in within 2 weeks. And I'll have my nurse call that next week usually to check in with the patient. I would encourage you guys to do that as well. Hopefully they're already in therapy, or if they're not in therapy, that also counts, right? And that also helps. Some kind of clinical contact. You can start spacing it out, especially if they're engaged in therapy. And so here's what we're looking for, right? There's not a lot of data that can help us guide yet, the durability of depression risk for relapse. But so a lot of it is based on the adult literature, which is fine. SSRI continuation, at least 6 months. I usually say a year. You've had one major depressive episode. We want to get you totally working, tip-top shape, relapse. And then after that relapse starts, the clock starts. And I want to see you on the SSRI for a year, at least, before we even talk about trying to come off of it. That's because these medicines can help prevent depressive episodes from recurring. Highest risk of relapse is within that first year. Okay. some things that make me think, yeah, maybe we need to prolong that, even with one depressive episode, is if they have that double depression, right? Persistent depression, some clinical, and then another major depressive disorder on top of it. Psychosocial stressors that could impact things, again, gets at the messiness of adolescent depression, suicidality. And then if there's any comorbid psychiatric conditions, maybe I'll kind of like recommend extending it out usually. There's been 3 episodes, I'll say, a lot of people just decide, to stay on these medicines for a long time because they're really well tolerated. I didn't talk too much about this monitoring either, but with teenagers, of course, alone, when I get them alone, I also kind of add the side effect of sexual dysfunction, right? So low libido or problems with performance. Of course, every adolescent will kind of, look uncomfortable, and I'll use that opportunity to just kind of medicalize things and say, hey, if this is an issue, just know that it could be the medicine, right? And so just let me know. So let's see here. And then medication therapy visits at least monthly to monitor for relapse within that first year. Therapists can independently do a type of therapy called cognitive behavioral therapy for depression relapse prevention. So they can kind of shift into that model. And that's kind of the tail end of an acute treatment phase for CBT for depression anyway. But it could be done monthly as well if we're really worried about kids. All right, so that's the end of my talk.
Well, thank you so much, Dr. Edwards. I'm getting a bit of an echo, so I apologize if you're hearing that too. We do have time for a few questions now. Go ahead and type them in the Q&A box if you have them. And if you go one next slide, please, Dr. Edwards. While we're waiting for questions to come in, I want to let you know about some of our future webinars. So our next one is April 15th at noon. Dr. Katie Kortz will speak on sleep in pediatric primary care. And then on May 19th, we'll have Dr. Cynthia Ellis speaking on managing autism in primary care. So we hope you'll join us for these two as well. And I'm seeing a question that's come in. Are there any metaphors or examples you use with parents or adolescents who are hesitant about or not interested in medication?
Yeah. I like to, I'm kind of biased. I come from the medical model, right, as a physician. So a lot of times I will liken it to another medical condition, right? And so I'll first of all normalize. It's like, yeah, it is kind of weird. It is kind of weird to take a medicine every day. And I will go into more detail. Number 2 is explaining a little bit more about how the medicines work. I'll say this medicine works on the serotonin system in your brain. It's one of maybe 5 big chemicals that our brain uses to modulate mood and anxiety. And so what I'll tell them is that this medicine, the way it works is that it helps your brain become more efficient at using the serotonin it already makes. It doesn't add any new serotonin, okay? So it just kind of helps your brain be a little bit more efficient. They're non-addicting. So there are a lot of other medical conditions and medical things out there like that. For instance, a lot of people your age might have to take a pill every day because they have a thyroid issue. Doesn't mean there's anything wrong with them, but they might just need a little bit extra help and a hormonal balance to help with that. Or of course, diabetes, some kids need to take it every day. Take insulin every day or medicines to help kind of manage that. And so, and depression is the same way. We view it as a medical issue. Doesn't mean you have to stay on these medicines forever, but it is something that is treatable with medicines that we know. And you don't have to tell anybody that you're on these medicines, right? If they look at these medicines, you can say you're on a medicine for a medical issue because that's what it is. So I kind of use that as a little bit to normalize things.
Great, thank you. The next question is, I know it takes a while for SSRIs to work. How long do you find it takes before children or adolescents experience some form of benefit from SSRIs?
Yeah, great question. So there's 2 answers to your question. what our evidence says is that we need to give it at least 4 to 6 weeks at very minimum. A lot of durability studies say it's really approaching 3 months. And so if I don't hear a history of a solid 3-month trial of at least 20 milligrams of Prozac, I'm skeptical, and they're adherent to medicines. I'm skeptical that that was an adequate trial. So if it's less than 3 months, I'll usually, I may try myself, just to make sure that it was a solid trial. So what I'll tell kids though, it's like, yeah, I mean, be patient. It usually takes 4 to 6 weeks after getting up to an appropriate dose. But you know what? I've seen this medicine start working after a week or two. Okay, it's not as common. We need to give the medicine time. But hey, I've seen it happen. If you start feeling better in a week or two, that's okay. We'll take it. So I'll kind of give them that hope, and I do see that. Some kids do kind of benefit from that. Initial serotonin surge a little bit while the receptors are kind of down regulating and modulating a bit while we're waiting for the medicine to work. They do feel better, but it's really getting at the placebo effect, which is really powerful, and I really do use it. And so I tell them a couple weeks. I wouldn't be surprised if you do have a response, but if not, just got to give time.
Perfect. We have time for one more, I think. Do SSRIs interact poorly with other medications? Are there any meds we should look out for?
Yeah. In general, these medicines have really low drug-drug interactions. But what I do is I run through a database, plug them into a drug check database. It's metabolized, so Prozac is metabolized through 2D6 in the liver, and so that's probably the biggest drug-drug interaction that we worry about. Any other medicines that are metabolized through there, so it's a 2D6 inhibitor. So Strattera, atomoxetine, used for ADHD, those are both kind of metabolized through the same pathways, so we might see effectively increased doses of Prozac. If we're using another 2D6 inhibitor at the same time. So nothing too big. That by and large are really well tolerated. I've had kids with, but we monitor for special things like bleeding disorders. If they have any factor deficiencies, doesn't mean it's contraindicated. It can technically lower the seizure threshold a touch, doesn't mean it's contraindicated in epilepsy. We use it in epilepsy. We also worry about interactions between these medicines and serotonin, other serotonin agents. Very high doses of Prozac really should be used with caution, with really high doses of like the triptans for migraines, okay, Zofran. So we just have to be careful with some of those potential side effects that can happen. But no, very few absolute contraindications, but we do check.
Perfect. I'll just wrap up here. It's noon. If you could scroll to the next slide. If you have any questions about the webinar today, you can email me, laura.holly@unmc.edu. Or if you want to learn more about the UNMC Telebehavioral Health Consultation Team, please visit their website that's shown here. I want to thank everybody for taking some time this afternoon to join us. And thank you so much to Dr. Edwards for his wonderful presentation today. Thank you so much, everybody. Have a great afternoon.